Hi. Okay, welcome back. We are on our module 2, signs, symptoms, and body changes. So this is all about what we are experiencing in perimenopause and menopause. And so I think this is going to be a very informative video. Of course, you are the one who's experiencing these symptoms. And if you are experiencing something that is not here that we don't talk about in this video, it doesn't mean it's not related to menopause. It just means that I'm not talking about it in this video. But there are so many symptoms, and I am amazed at what patients tell me about, or I also am on some of these Facebook groups and listening every day to what women are complaining of. So these are important things that are going on with you, and I want you to know that you are not crazy. And when doctors tell you, "Oh, it's nothing," or just to ignore it, maybe you know you need to advocate more strongly for yourself or find someone else who's more knowledgeable about menopause and perimenopause. Okay, but sometimes they're just not knowledgeable. That's all. Doesn't mean they're bad, just means that they need to be informed. And that's why you're here. So I'm here to just give you education and information. I'm arming you with that so that you can go to your provider, your doctor, your nurse practitioner, your PA, your naturopathic doctor, and like have information and be confident about what's going on and what you may decide you want to do. And so, again, this isn't medical advice, and I'm not getting paid by any drug company or uh, any lab or imaging company when I give you advice. So, we'll talk about the most common symptoms and help you recognize them. And there's only one lesson in Module 2. So, the next video will be Module 3. So vasomotor symptoms are the most common symptoms, and 75% or up to 75% of women do experience them. And when we talk about vasomotor, we're talking about the blood vessels dilating and constricting, which is what is contributing to hot flashes and night sweats. So some women will just have hot flashes, some women will just have night sweats, some women have both. There's not really an explanation for why you have one or the other, and why you might have it more frequently than someone else. That's just a variability from one person to the next. So again, majority of women do experience hot flashes, and it has to do with estrogen. Remember, we talked about estrogen and the hypothalamic pituitary ovary axis. Okay, so we know that estrogen does cross into the brain and does impact, or the hypothalamus is able to sense how much estrogen you have. That's how it sends that message to the pituitary gland to then stimulate your ovaries. Okay, a lot of information there. But there is the thermoregulatory center of your body, which is the center of where temperature is controlled in your body, is in the hypothalamus. So when you don't have enough estrogen, it causes, or you have fluctuating estrogen levels, it causes instability in the hypothalamus, in that place that regulates your body temperature. So, and then that's what causes the vessel dilation, then constriction. When the vessels dilate, that's when you get the hot flash. Now, why do some women will say, "Oh, I just get it on my back," or it starts in my back and then goes? I don't have an explanation for why it starts in one place or another, or why some women only experience it in some parts of their body, but it's all valid. So night sweats. Night sweats are, hot flashes are really bothersome and annoying and embarrassing, right? You're in a meeting at work and suddenly you're sweating and you're making a presentation. Um, But night sweats have a secondary sort of impact in that they're affecting your sleep, right? Your covers off, covers on, windows are open, fan is on you. There's a lot of ways that women deal with night sweats. And of course, your partner is freezing on the other side of the bed. Um, but sleep disturbance is associated with higher rates of cardiovascular disease and even some cancers. So getting that good night's sleep is so important. If you don't do anything else and you want to suck it up with symptoms, the one thing you really need to try and get taken care of is getting that good night's sleep. Actually, not sleeping well it causes weight gain too. So most sleep doctors, or actually obesity doctors, when they're talking to patients about risk factors for obesity, they want to know how well someone's sleeping, and if they're not getting good sleep, that can contribute to obesity. Okay. So the next big category is what we call now genitourinary syndrome of menopause, or GSM. But we have called it vulvovaginal atrophy, which just sounds not as good, right? So genitourinary means this part of your body, the genital area next to the bladder. Here's the vagina, and the bladder is right on top of the vagina. So uh, and then the urethra, which takes the urine from the bladder to the outside. So this is all kind of interconnected. And so in menopause, what is going on as the estrogen declines in this area, it impacts your health there. So you can get, as estrogen declines, the tissue becomes less stretchy. You have lower blood flow to the area. So think about that in terms of lubrication, in terms of painful intercourse, what we call dyspareunia. And then it also, declining estrogen levels will impact the vaginal pH and microbiome, the bacteria that you naturally have in the vagina. And then that will potentially cause more vaginal infections or even lead to urinary tract infections. Because if you have different bacteria and then you have intercourse, then those bacteria can get into the bladder more easily. Also, with the anatomy changing, and the urethra may not be as, the tissue around the urethra, keeping the urinary opening closed, may not be as strong. So that may lead to more urinary tract infections. And then even if you don't have a UTI, because the vagina is less stretchy, it's right next to the bladder. So if the vagina can't stretch, the bladder can't stretch. The bladder isn't going to stretch the way it did before, and you have more risk for urinary frequency. So feeling like you got to go all the time. Yeah, fun stuff, right? Okay. And with those changes, before we just talk in isolation, talking about sexual dysfunction, right? Having less libido and more difficulty, getting interested or even being aroused or having orgasms, and then how that affects your relationships. But think about if you're not sleeping well, okay, because you're having night sweats. Or just some women just have insomnia without night sweats, by the way, in menopause. So you don't have to have night sweats to have sleep disturbance in menopause or perimenopause and menopause. So you're not sleeping as well because of the decreased estrogen levels, because of perimenopause. And then you're tired during the day. So it makes you more tired. And when you're more tired, you're kind of not as interested in having sex. So it all goes together, regardless of whether you have high testosterone, low testosterone, where your estrogen levels are. If you're tired all the time, you could be 20. If you're tired all the time, you might not have as much of an interest in having sex. So fixing that sleep really has an impact for everything down the line. Okay. So now when we talk about decreased libido, strictly related to menopause, it is related to that decreasing estrogen levels, and actually how it impacts the ratio. We talk about the ratio relationship between estrogen and progesterone. There's a relationship between estrogen and testosterone. So when you have so what they're kind of fighting for, a specific sex hormone binding globulin. It's like a protein that they both want to bind to. And if you have less estrogen, then more of that binding globulin is available for testosterone to bind to. And if you have more of that available for testosterone to bind to, then there's less of what we call free testosterone, which is the testosterone that actually helps you to have a better libido. So ways to increase free testosterone is actually by increasing your estrogen and progesterone can actually free up more of that sex hormone, free up more of that testosterone. Okay. All right. Other symptoms beyond the vasomotor, genitourinary syndrome of menopause. There's so many other things, right? We talk about weight changes. A lot of women complain of more fat, like gaining weight, and instead of it depositing on their hips and butt where it used to, now it just goes to their tummy. And then if you have more tummy fat, you have a higher risk for pre-diabetes and diabetes, which is what we call metabolic syndrome. And that combined with obesity. So what is going on? So estrogen, there's two things kind of going on here. Estrogen helps lower insulin resistance. Insulin resistance, what is that? Okay. Insulin resistance is where your tissue, your body uses glucose all over the body. Everything you eat gets converted into glucose. And your body needs insulin to convert to get that glucose to go into the body's cells. This might be more than you want to know. But if you have insulin resistance, you have to have higher insulin levels to get the same amount of glucose to go into your cells. So your body is working harder to use the same amount of food, basically. At the same time as all this is going, as you're aging, your muscle mass is decreasing. That's just from getting older. And that's why it's so important to actually maintain your muscle mass by doing resistance training. As your muscle mass decreases, you also develop more insulin resistance because muscle helps improve insulin resistance because the insulin can works much more easily when you have more muscle. When you have less muscle and more fat, then your body has to create more insulin just to get the glucose to go down, to not have a high surge, right? If you have diabetes, your glucose levels are too high in your bloodstream. And you have to some people take insulin, some people take medications that work directly at the cells to move glucose into the cells. But the idea is you develop insulin resistance when you have type 2 diabetes. So this is the beginning or heading in that direction, potentially, if you don't prevent obesity or reduce the risk of obesity or lose weight and don't develop enough muscle. So don't be afraid of doing weight training of course, like if you're not used to doing, you're not educated on it, you need to have someone coach you and guide you. But those are things that are going to help you avoid or lower the chances of insulin resistance as you age. Yeah, so there you go. Now, there's another factor in the gaining weight in the midsection is also, and that's helping contribute to the insulin resistance. We talked a little bit about in one of our previous talks about cortisol levels. Cortisol is also increased from the adrenal glands, and cortisol causes glucose levels to go up and more insulin resistance. And so your body is just overall working harder at this point to do the same things it used to do just fine. Oh, yes. Many women complain of thinning hair, brittle nails. These are all it's a lot of it is multifactorial. I don't want to blame it strictly on menopause because some of it is age. And then we also need to think about diet as well. So while estrogen can help with those things, with thinning hair and with your nails, there's, their diet is very important. And so, so certain diet, like certain vitamins from your diet that you want to have, and also genetics play a big role here, especially in the thinning hair. Wrinkles, aging of the skin, also very estrogen driven because of the collagen changes in your body. So as collagen decreases, you don't have as much of a firmness to your face and you have more wrinkles. The other thing that's happening, this is really kind of another crazy thing, is you actually have bone loss. If you think about, like, we all lose amount of bone over time. If you want to maintain bone in your arms and legs, your spine, you do exercise, and that helps to prevent bone loss. But you actually lose bone in your facial structure. This is what I learned from a dentist. And that is kind of what helps to promote kind of a little bit of changes in the facial structure and how things look like they're sagging more. And so having more collagen, like maintaining your estrogen levels, can help lower that, but it's not going to completely prevent that. Oh, I actually want to go back a second and just mention that there are studies that, in addition to using the oral estrogen or systemic estrogen through a patch or a gel, estrogen getting into your bloodstream, there's a lot of more studies going on right now with the topical estrogen. So it's not yet a standard of care to use a topical estrogen, but there are promising studies with topical estrogen on your face to prevent wrinkles. Okay, this is a big one, right? I mean, I think a lot of women experience mood problems, anxiety, irritability, depression in perimenopause and menopause, as well as brain fog, memory lapses, executive function decline. What does that mean? Like, you used to be able to take care of 5 zillion things all at once, and now you're forgetting to do things. You're struggling to get just the first thing done on your list. So a lot of women who might have had maybe a mild ADHD, suddenly they're officially diagnosed with ADHD in perimenopause and menopause, forgetting a name, forgetting, oh, where did I put that? Those are very common occurrences with the decreasing estrogen levels. And when we talk about mood, I also don't want to forget to kind of stress that the sleep disturbance can be a big part of the mood issues. Not necessarily, like for some women, you're just going to develop, may trigger mood issues at this age, the decreasing in levels of hormones. But for some women, if you fix the sleep problem, then the anxiety, depression, or irritability are going to improve or go away. I have had, I think, two patients over my 25 years practicing who developed psychosis, which is a very severe psychiatric problem during, I think, that kind of triggered by perimenopause, by decreased in hormone levels. Okay, well, yes, headaches, migraines can worsen in perimenopause, but a lot of times I've seen that maybe they worsen in the perimenopause time and then kind of go away in menopause. So this is kind of an interesting relationship. It is very individual for each patient, depending on how they feel that the hormones have impacted their migraines over the years. And so if it's the fluctuations in hormones that are contributing to the migraines, then being on hormone therapy, stabilizing the hormones may help until menopause. And then joint and muscle aches, arthritis is actually, or they told me arthritis is more common in women in your hands. It happens to come on at the age of 40, and usually the pain eventually goes away, or 40 something. Well, it's actually because it's triggered by the decreased estrogen levels and how they impact the connective tissue. So, uh, this is really a no-brainer, but a lot of primary care doctors don't recognize that when women come in with joint pain or muscle pains, it's actually related to perimenopause or menopause. All right, this is an important thing I want to talk about, which is bleeding, abnormal uterine bleeding. So we're going to talk about abnormal bleeding in perimenopause before you get to menopause, and then abnormal bleeding in menopause, which is called postmenopausal bleeding. Okay, so abnormal uterine bleeding in perimenopause, sometimes we call that perimenopausal bleeding. If you can go back and remember there was a slide with the estrogen levels, and that in perimenopause, estrogen levels are still kind of high, but the progesterone has really dropped. So what's going on there? If you are having periods that are not spacing out, but instead they're getting closer together, or your periods are heavier than before, not lighter than before, you could be having this problem where the estrogen levels are still up, but the progesterone is not high enough to thin that lining inside the uterus. So you are shedding more frequently, or heavier, or both. Okay, we call that perimenopausal bleeding because there's that imbalance between estrogen and progesterone. And that needs to be evaluated by someone who specializes in gynecology, because you may need not just an ultrasound, you might need a biopsy of the lining of the uterus as well. Yeah, so maybe you need both. Um, it could be caused by just the hormone changes. It could be caused by a polyp, endometrial polyp, or a submucosal fibroid, which is a fibroid on the inside of the uterus, or fibroids in general can cause heavier or more frequent bleeding. But very rarely it could be caused by uterine cancer or uterine precancer, okay, or what we call hyperplasia. So we don't poo poo this, we don't ignore this. Heavier or more frequent bleeding needs to be evaluated by a physician or provider who specializes in gynecology, knows what they need to do, and does not blow it off. You might need hormonal therapy to control the bleeding. Okay, so that's before menopause. Once you get to menopause, once it's been 12 months with no bleeding, and then you have some bleeding, whether it's just spotting, staining that looks like blood on your underwear, or full on red blood, any of those three things needs to be evaluated. Okay, so, and by evaluated means you're going to need at least an ultrasound or an endometrial biopsy, or both. So with the ultrasound, we're looking for the lining of the uterus, the endometrium, to be 4 millimeters in thickness or less in menopause. If that's what it looks like, then we usually don't need to do a biopsy. But some doctors or providers will go ahead and just do a biopsy to be more certain, or they'll do the biopsy first instead of the ultrasound, and that's okay too. But then if you continue to bleed and you've had a normal biopsy, you need to get the ultrasound. Might be more information than you need, but I'd rather you know this, and you have these, you can save this for later reference. If this ever happens, you're going to go back and go like, oh, Dr. Steinberg said, so let me go back to that video. What did she say needs to happen? Okay. Now, I want to kind of differentiate this kind of postmenopausal bleeding from bleeding that might happen in the first 6-ish months if you get started on hormone therapy. So if you're in menopause and your provider starts you on hormone therapy, sometimes there's come kind of irregular, there can be some bleeding as we figure out what the right dose for you is as your body adjusts. Okay, well, I want to talk about something that's not talked about very much. I don't see it out there talked about very much, but it is important, which is intimate partner violence. That's what IPV stands for. And your women are more at risk for intimate partner violence, specifically in perimenopause and menopause, because you're having mood problems, you're maybe stressed out about your job, like there's a lot of things going on. You've got the aging parents you're dealing with, you've got your kids, you've got your partner's needs, and you're moody and you're not wanting to have sex as much, and that puts you at higher risk. Okay, and it's not okay. Violence is not okay in a relationship, and you need to seek help locally. So there are hotlines in every jurisdiction in this country or in the world, I hope, and you need to seek help. It's not okay. All right, so our summary key takeaways: most common things are vasomotor symptoms, genitourinary syndrome of menopause is GSM, and sleep disturbances. And sleep disturbance, remember, can be independent of the night sweats. You could just have sleep problems. Then we talk about body changes like your weight, your skin, cognitive problems where you can't remember things, your mood, irritability, you're having pain, all sorts of pain, joint pain, muscle pain, hand pain, and bleeding. Bleeding issues are really concerning, need to be evaluated. And then the social impacts, obviously it can impact your relationship if you are moody, but we don't condone any violence. Intimate partner violence is not okay. Please seek help if that's going on. But also seek help if you're just having mood symptoms that are affecting your relationship potentially, because this is a time that's a high time for a lot of relationships to fall apart. And potentially treating menopausal symptoms may improve your marriage. So consider that. Okay. All right. That's the end of this one. I'll see you next time.